we go, brother.
Hey, man. How's it going?
It's going well, my man. I brought a little visual treat for you. I don't know
Oh, I love that, man.
if you can see my man
J
here,
Dubs. J Dubs.
J Dubs. I thought nothing more appropriate to talk about some manly topics than the man himself.
That's right. He is a man's man.
He is. He
Jocko
is.
Willink. Love it, man. Cool guy.
Yeah.
Love his
Yeah.
stuff. Good. That's one of the best. That's one of the best speeches I've
It
ever
is.
heard on the
It
internet
is.
in the personal development space. What do you think? Have you ever seen him do jujitsu as a? Are you up to a purple belt?
I'm
What
a
are you
purple
now?
belt, yeah, now.
What do you think of him as a? Have you ever seen him do jujitsu?
He's a skilled practitioner for
Is he
sure.
seriously? I mean,
Yeah. I mean, he's a high level black belt trained with.
he's a black belt. I didn't even know.
Oh yeah, I mean,
I know.
you
I
can
know
you
he's a
can
big.
Google some videos of him with he trains with Dean Lister.
Oh, jeez.
There's some
That's a big
significant. He's been in the game for a while. This is not a new thing for him.
Did his stuff was a lot of that crossover from Navy SEAL training, or is that just something he sought out on his own?
You know, that's a good question. I don't know if I know that story. I don't know that it's significantly pervasive in SEAL training. That's probably something he did on his own, especially at the level he does it. Right? They probably steal some techniques and some things for SEALs
Just
and
general
police.
hand-to-hand combat.
Yeah, but not the level he does it. Like he's done some high level competitions and some high level.
So his black belt was through Dean Lister BJJ, or
he trains with Dean Lister currently. I don't know who he got his black belt from. I'll tell you, neither one of us would like to go on the mats with him. I can tell you that would end very poorly in a very quick fashion.
What?
Plus, he just looks like a beast.
He does, dude. He is such a beast.
His hands and arms, and
he's just a big dude.
Yeah.
What's your lineage? What's your BJJ lineage?
What is my BJJ? I don't even.
Are you through? Is it a Brazilian thing? Are you through?
It is. I do Brazilian jiu-jitsu here in town. Felipe, Zikro, Felipe.
If you got your black belt, would it be a Gracie? I mean, what is your? I mean, like, where are you? What's your?
No, it's not through Gracie. I train with Alliance. Is the name of it?
Okay.
Alliance Jiu-Jitsu. They have quite a few studios around currently. I've bounced around because I traveled. I did some in Alabama. That was a non. I started with Felipe at Alliance when he first moved here from Brazil, actually.
Oh, really?
Well, I guess technically I first learned from one of my chiropractic classmates.
Oh, really?
And then trained formally under Felipe when he first
just
started.
Just goofing around, or like was that?
No, I had a jiu-jitsu gym, and he was a
okay.
wrestler and did jiu-jitsu, and we were watching UFC, old school UFC, and like, let's try this, and
nice.
But now trained under Felipe. I'm back with Felipe. Did a couple other gyms and have now ended back up under one of his instructors.
Other than the sense of community, trying something difficult and overcoming something difficult, exercise, using resistance, your muscles, your
sure.
What are some of the things that maybe aren't so obvious, or obvious for that matter, health benefits of jiu-jitsu? Because a lot of people in this space tout it, and I believe in it, but I mean, for you, you're way further along.
For me, I call it Fight Club Light. There is something to be said about being in a position.
Jeff, do you have this? We need. You know what we need to do, Nick? Producer Nick. We need. Jeff has got. Dude, you've developed some dimes, some pearls along the way here. This is
the sayings.
This is good. We need a lexicon of Jeff. We need a whole book of. He's got it all. It's awesome. He boils it down to a couple phrases. You notice that? That's really cool. Fight Club Light. Okay. Tell me what that means.
Well, there's something to be said for having somebody have their arm around your throat and the feeling of potential hopelessness, and learning to calm your mind, learning to know where that line is, when you should tap out, when you don't tap out, where the line is, and feeling physical pain in compromising positions. That is,
what do you mean by learning where the line is? Like how much you can withstand, or
yeah.
Okay.
And then the feeling of helplessness, like I don't think people understand it you can understand it in a verbal sense, but when there's a high level practitioner that maybe has your back or has control position like a knee on belly, and it doesn't appear to be that problematic, but you can't move, and they're just slowly sucking the life out of you in a controlled sense, and you have to, are you going to keep fighting, or are you just going to give up? And you learn where that line is, and you give up a lot, and then you come back again, and then you learn that maybe I can withstand a little more pain, and maybe I can withstand a little more force, and maybe I can get out of this. And so for me, just on a daily basis facing that is, and then being able to inflict that, there's some masculine
I was going to say,
necessity
what
to
is
that.
that? Yeah,
I
to learn your masculine. So I when I did Weichiru karate like Dad did, remember? And I was a black belt in Weichiru, so I was working with Roy Bedard, who's still in Tallahassee, I believe, and he's still around in the Weichiru community. Amazing martial artist, amazing martial artist, Roy Bedard, and he had this theory that you had to, and it's kind of Jordan Peterson-esque, like you had to recognize the violence within yourself, acknowledge it,
sure.
and control it,
Mm-hmm.
and not, so that you didn't become abusive. You didn't, and
It's true.
for him, martial arts allowed him to master that in himself and teach others.
Mm-hmm.
And then it wasn't that it was just masculine. I mean, women have masculine traits, just like
Sure.
men have feminine traits. So it wasn't, I don't mean this, I'm not trying to pigeonhole, but
yeah, I can't speak to the feminine mindset. I could just speak to me as a male. I have a necessity within me that seems to be innate, that I like a certain level of violence. Now I've been it's been pushed down over the generations, and I don't necessarily want to go to war, and I don't want to have a knife fight with you.
right.
But get on the mats, and we have a agreed set of rules, and something bad could happen, and I could get
Pitting yourself against another human being.
Yes.
In that sense, yeah.
Yeah, it's hard to explain, and it's a little bit safer than getting punched in the face, which I don't necessarily like, but have had happen to me, in various settings. So I think,
yes, I remember.
We can have a generational talk, but I think that generation just, but I think it goes to your broader point. Like, I know now that there is a certain level of aggression within me that I have learned to master and control, but not dampen, but control. I can focus it, and I can use it if necessary, or not use it when not necessary, as opposed to being a slave to my greater emotions.
Exactly. That's key. And we don't need to strip that away from men. We don't need to deny that in ourselves, men or women, but we do need to learn to control it. And maybe by identifying it and then learning to control it, that's the proper. That seems to be the proper way, as best I can tell. I'm reminded of a podcast that's all over YouTube and certain various clips. And you've probably seen it with Jordan Peterson and Joe Rogan, and a couple cool things that they said were so Rogan says to Peterson something about it, what Peterson said to him reminded him of better to be a warrior in a garden than a gardener in a war.
It's true.
And that's for sure. And then Peterson says something like you shouldn't avoid I'm very much paraphrasing, but you should become a monster. You should become a monster and know the full potential of your wrath and your violence or whatever, and then learn how to control it.
Control
right?
it. Yep.
Because not being not dangerous doesn't serve anybody. Knowing what you're capable of and then controlling it and learning how to emotionally do it, that's when you're serving humanity, so to speak.
Yeah, I agree.
On that topic, we should talk about testosterone. What do you think?
Yeah, I agree, man. That's what we primarily, at least I primarily do in our practice, and I know you do a lot of it as well. And that's one of the topics that comes up. Maybe we'll just use that as a segue. That's probably, I got this question yesterday in the clinic. He's like, my main concern is, will I become aggressive? Will I get roid rage when I take this testosterone?
Did you? So, I get that a lot too,
yeah. How would you?
What do you
that?
Say?
What do I say? So this is what I tell guys. So this is what I tell guys. This is probably a common question. I say, good question. Something we need to address. That's a common misconception. I start out by saying, well, I just answer the question bluntly, and as I see it, the opposite is true. It calms men down a lot of times, significantly. I've never seen a man on testosterone replacement get aggressive. And here's how I explain it to him: is when you feel well inside, when you feel full, when you feel confident, when you feel your complete sense of self from an energy perspective, from a mind sharpness perspective, you are you just feel good and you're slow to anger. But when you're short on all those, when you're a little bit tired, you're sleeping a little bit poorly,
Right.
you don't feel as good. There's a strong sense of well-being that is derived from testosterone for males and females, but in this case males that we're talking about, that when you don't have that, you get really short and you have a short fuse and you snap. You're not necessarily aggressive in the sense of like physical violence, but you're just short with people and you don't give anybody any leeway. A lot of my examples come from children, and I always explain it this way, right? Your little son or daughter goes to grab a cup off the shelf and they drop the glass, it shatters, and you're like, damn it, I told you don't grab cups.
Yeah.
And then you step back and you're like, why did I just yell at him?
Yeah.
But when you feel good inside, you're running on all cylinders. You're clicking at work. You're a better employer. You feel good. You're driven. That same incident happens, and you're like, "Dang it! I'm sorry, buddy, man. We should have had plastic cups up here. Everyone to the car. We're going to Target. We're getting all plastic cups. Family trip, right?"
Yeah.
And that's the difference that happens. You just feel good, and so you convey that confidence that comes through in your daily interactions.
Yeah. That
Um,
confidence. Yeah. And things tend to roll off your back. We know that.
yes, for sure. I tell
When
people
you're
this:
optimized.
when you're optimized, we're not going super physiological, we're not going silliness, but you rarely hear of, I don't know, professional boxers getting in bar fights. You rarely hear of,
That's so
if
true.
ever, MMA fighters, because they're like, dude, seriously, two guys, you don't want this, man. Like, come on, just back
Mhm.
away. I don't want anything. There might be something bad that happens, right? I feel good. I know I'm confident in my levels. I'm confident in how I feel. I'm confident in how I perform. And so I walk away from things. So yeah, I don't ever see that really. I've never actually seen it in my practice, period.
Yeah, and I mean, there's a lot of biochemical basis to that, how testosterone affects neurochemistry,
Mm-hmm.
how the lack of it affects neurochemistry, and how feeling well affects neurochemistry. When you don't feel well, you get a short fuse. I mean,
Yeah.
we know that empirically just from states of illness that we can find ourselves in,
Mm-hmm.
lack of sleep to actual acute illness. And yeah, I people always ask that. It's a big concern. It's a concern a lot of times for female partners of men
Mm-hmm.
that come in, and I tell them the optimized male is so much more fun to hang out with
Yes.
than their non-optimized self. And you get
Mm-hmm.
this like it's almost like a low. It's almost like a it's like a lower level of hypomania. Like it's definitely not manic. It's definitely not quite hypomanic, but you just have and it's not euphoric. It's like sub euphoric. Like you just feel well in a
Mm-hmm.
way that you haven't before, especially going from that depleted state to that optimized state.
Mm-hmm.
And so I find that men, and let's see if you agree, but they're gentler actually. They're more loving. They're
Yes.
more kind. They're kind of more compassionate. Things roll off
Mm-hmm.
the back, both males and females. Things don't seem to be. And we know that testosterone is a natural analgesic, um, and uh, it's an anxiety reliever.
Mm-hmm.
It's a natural antidepressant, right? And when there's biochemical studies on the neurochemistry there that we can point to. But I think that if you get ultra high doses, then you start to look at, if we look at anabolic androgenic steroids, right?
Mm-hmm.
Synthetic allele steroids, you could classify them, and people have done this, that this one's more androgenic than it is anabolic. This one's more
Mm-hmm.
anabolic, that, meaning promoting nitrogen retention in the body and inducing muscle mass growth and etc., hypertrophy, um, or this was androgenic, right? It's going to affect the neurochemistry
Correct.
and cause aggressiveness. And then in synthetic hormones, you could see so-called roid rage.
For
And then, of
sure.
course, in some of the corticosteroids, we see people have mania or irritability, like, the prednisones and their derivatives,
Mm-hmm.
the adrenal hormones. But in testosterone, I don't find that. Um,
Yeah, the only time I've ever seen it in my practice is when someone comes in and they're trying to get off of a synthetic. That is a
yes.
known effect, and in my clinic, I have I have an open door policy, so to speak. With I don't judge what you're on, but like I don't prescribe those. But if you're on them, let me know. Let's talk about the risks,
Yes.
and that is one of the big things that is a risk, and that's why a lot of guys get off of it. It's just the bang for your buck is not there in synthetics, and I'd never recommend them. There's so little benefit to risk ratio, whereas testosterone replacement is the exact opposite of that. Testosterone
Absolutely.
replacement, high bang for your buck, low risk. But I think a lot of physicians and a lot of lay people have confused the two, right? Anabolic steroids and testosterone replacement.
Conflated, really. I mean, they
Yeah.
conflate them, really. It's sad because they're missing out on the benefit of it.
Yes.
Now I will say one of the issues that can occur is, and a woman will tell you this, and it's not to, it's just the physiologic reality of being a woman and having a menstrual cycle and fluctuating hormones more so than men do. If you don't get the estrogen right, you can sometimes see problems with sleep, irritability, among the other things that we know, breast tenderness and flushing and things. And I find that can be managing or not managing well can make it, not managing well can break it. So the funny thing is that not so much the testosterone always, but the management of the estrogen side effects, right? And so just for the audience sake, we know that in the body, testosterone is converted to either dihydrotestosterone DHT by 5-alpha reductase, or in the case of estrogen by aromatase, so testosterone to aromatase. And it's not that we don't need it in a man's body. We do need estrogen. It's not just a female's hormone, but in excess, it can be a problem. Do you agree with that? And then how do you manage estrogen in your patients?
Yeah, I agree with it. I think the male's physiology can handle testosterone. It's a wider range of dosing that gets you the effect that you're looking for. Estrogen, however, very small window of levels that can make big pronounced effects. I tell my patients the difference between somebody doing it on the side and somebody doing it as a main patient-based source is their ability to control estrogen. I see one of two things. The most common thing I think I see, but they're both pretty equal, is we just smash estrogen altogether, or we don't even know that that's a potential problem, right? Those are the two dichotomies. The most common thing I see is like take a whole pill of an anastrozole, a whole 1 milligram, every time you take a shot. It's like, holy moly, you're taking 2
you
milligrams.
see it that bad?
Yeah.
Daily 1 milligram of anastrozole.
No, every shot. Sorry,
I'm
every
sorry.
shot.
Excuse me. So like maybe once
like
a week,
twice a week, or
once a week, or twice a week.
Yeah,
a
usually
whole
twice
milligram.
a week. So, there was a good study. I would call it a study, observational piece that came out of Low T centers. They're a big multi-practice clinic based out of lots of states, but primarily in Texas. And they did a good study to look at their practitioners and look at their data of estrogen, how it's controlled, what AI did they use, what aromatase inhibitor did they use.
Observational data, it's kind of a qualifying type of study, yeah.
And just looked back at their studies they had like 17,000 patients in these clinics on testosterone. So a huge number of patients from I forget I want to say a 5-year window, 2009-ish to 2015-ish, maybe like somewhere in that range. 5 to 7 year window. So it's just, I think it makes or breaks the practice of testosterone.
What do they find in that?
So they found that they were looking at libido, they were looking at the type of prescription, and then they were looking at libido, gynecomastia, the AI prescribed, as well as whether or not docs always prescribed it. So they found that about 30% of the docs always prescribed it, regardless of symptomology. They found that anastrozole is the most common one that was prescribed. They also found that some docs commonly use some selective androgen receptor modulators, some SERMs, to modulate estrogen. They found that the biggest skew was in the age of the patient. So the younger crowd had less of an issue with estrogen. They had the older crowd had a higher problem with
Now
estrogen?
that's fascinating
Yeah.
because I've seen that empirically, and we've talked about this,
Mm-hmm.
where I have had older men come into my clinic and post-operative follow-up, and I don't know the exact genesis or what was the impetus to do this, but checking their testosterone and de novo. These are not people on
Right.
testosterone therapy. What I have found, and again, this is empiric data. This is not published research. Everybody, this is n of maybe like 15 patients, but it was just shocking. What I found was that almost to a T, the older the man, and I'm talking 55 or older, they had this naturally occurring, they would have these lower testosterones. That's not a shocker. But what was interesting was they had this naturally occurring higher level of estrogen that
Mm-hmm.
was way out beyond the quote unquote normal or high normal range. That threw me for a loop. I was shocked by that. So it's interesting to hear you say that because that kind of validates my empirical observation.
Yeah, I think I see this in a subset of older men. There's this, and I haven't figured out what the precursor to this is, but there's a certain subset of men skews higher in my observational data, my practice, the older men, 55 and older, that just have naturally occurring higher estrogen levels. We're starting to see some data come out that high estrogen levels may be more associated with prostate cancer. It's definitely adverse cardiovascular events.
Absolutely.
It's the chicken or the egg. Sometimes we're not exactly sure, but it's definitely interesting observational. So
You're well. Hold on, I just want to stop you there. That's a really good point, and that can't really be understated. The chicken, the egg, and it also we can talk about accepting falsely or rejecting falsely the null hypothesis. So type 1 and type 2 errors, true and unrelated. Because what again, we're still trying to figure this out, and I'm not here. I'm not saying that this is or is not, but it just is a interesting food for thought. If aromatase is predominantly found in the peripheral fat, okay,
mhm.
and not so much in the lean body mass in the muscle. And if in general, as you age, there's some element of sarcopenia, unless you mitigate it with resistance training and or protein intake or some kind of promotion of an anabolic environment. On average, you're going to have the average person. You're going to have less muscle and more fat as you age.
Sure.
So there's going to be at least the reasonable environment in which there'd be more fat cells, or at least fat per se, volume maybe percentage, not cells per se, but which then could mean that there'd be more aromatase to generate more estrogen, right? You're gonna have less estrogen or less testosterone receptors, less quote unquote consumption by muscle of testosterone to further promote more generation of testosterone. And but is the health problem, is the estrogen a marker of the health problem of
Mm-hmm.
sarcopenia and less functionality, or is it really the cause? And I think it may be both. Even is my
Sure.
bias, because we know that, for instance, we know that exogenous estrogen tends to be a thrombogenic, a clot forming, a clot promoting
Mm-hmm.
substance. So much so that in the cases of myself as a general surgeon, in that hat I wear, when we have some of these difficult to treat GI bleeds, we will literally, even in the
Oh,
hospital
really?
setting, prescribe synthetic estrogens on purpose to males to promote clotting, because the clotting is less of a risk in that situation where you're literally dying
Right.
from bleeding or
I didn't
slowly
know
dying
that.
from
That's
bleeding. Yeah,
interesting.
it's very, very interesting. We don't, but here's an interesting thing, right? We don't prescribe testosterone. You know,
Sure.
well, if testosterone was such a clot promoter, or causing
Right.
intraluminal clot formation acutely, which would then cause a heart attack, then why is it estrogen that we're
Interesting.
again, like you said, that estrogen has some
Yeah,
side
the
effects.
estrogen control in testosterone replacement therapy, I think, is integral. I had always heard that early in my practice that the higher the fat content, the higher the aromatase, the higher the conversion was the sort of premise. I
But
don't
you
see
don't
that.
see that.
I don't see that play out in my practice from people taking exogenous testosterone. I can't tell you a bigger guy with more fat by visual assessment does not necessarily convert more of his testosterone replacement therapy to estrogen. I have not been able to pick that person out. Um,
Well,
and
let me ask you this. There's in the world of bro science. Oh, hey, you're an estrogen converter, or oh, hey,
mhm,
you're a DHT converter.
mhm.
Do you think that genetic predisposition to be a higher estrogen converter exists just from empirical observation?
150% yes.
Yeah, I do too.
Absolutely.
I see that.
Yeah. I have steadily brought my estrogen control down to really, I probably do it on a finite stage much more than any practitioner I know. I use quarter dosing of an anastrozole instead of whole or half pills. I
Has
use
it shocked you how powerful that drug is?
oh man, it will, yes.
It's
Yeah, because you
insanely
can't go the other
powerful.
way, right? You can't smash it. You can't just say, because a lot of times the guys, other than sexual side effects, they don't necessarily feel the low estrogen early on. They'll feel the high estrogen, but they won't feel the low estrogen. But
Yeah,
it's a strong, quickly acting too. It's a quick acting,
it is.
strong.
And now you said something interesting. You said other than sexual side effects. Give me an example of what you mean by that. In the setting
From low
of
estrogen.
yeah, from low estrogen.
Yeah, guys who are smashing their estrogen to a
When you say
zero will
smashing, you mean reducing it to
reducing it.
nil.
Sorry, yeah, reducing it down to way below because either they're doing it on their own or they're doing with a practitioner that doesn't quite understand it. And they're taking a large amount of anastrozole. They'll see erection difficulty and sometimes
There
low
you
libido
go.
and erection
Yeah,
difficulty. And
yeah.
that was one
So
of the things that they looked at in this study was is high estrogen a problem in this low T
Nick, here's
centers
something
article?
interesting to set up this next thing. Producer Nick, can you see if you can find anything real quick on? And maybe Jeff, does Huberman have anything on YouTube or otherwise on any other platform on the neurochemistry of estrogen? And let me give you an example why I'm asking that, or let me explain why I'm asking that. One of the things that was really interesting to me is you're absolutely right, Jeff. I agree with what you said. And one of the things that was interesting to me was learning the role of estrogen in males and the role of testosterone in females because
Sure.
and I'm sitting here before you as a living example of this. I was taught, you know, uh, you know, testosterone is the male hormone, estrogen and progesterone are female hormones. But reality is that both sexes need the converse hormones or the opposing hormone. And so what I have, as best I can tell from the literature, as I have currently learned it and researched and looked at it right now, a big part now testosterone is going to play a big role at the level of the gonads, at the level of the sexual organs, the blood vessels of the sexual organs, the physiologic response, and it plays a big role in the neurochemistry, but indirectly in the what I mean by that is at the level of the neuron after you cross the blood-brain barrier and in the psychogenic and neurochemical response, if you think about think about sexual intercourse in general, estrogen plays a massive role at that level.
Mm-hmm.
And so it's funny I got to thinking and see if you agree with this. This is just deductive reasoning. That's not. I don't know the exact. I don't have an exact study to point you to, and maybe find something with Huberman. But if you are an older guy and you are complaining of poor libido, this is outside of function. This is just purely libido. You makes you wonder, and then you have low testosterone. Oh well, it's the low testosterone cause it. Yeah, is it, or is the low testosterone, which is what the source of your estrogen, thus giving you a low estrogen, causing the neuro? So it's interesting. Huh? Have you ever? I mean, do you agree with that potentially being a
for sure? Like you see sometimes lower aromatization, and is the problem with guys having that low aromatization that just had low testosterone to start with, right? And so that's part of that sexual. It definitely plays, estrogen definitely plays a role in sexual performance and libido for males.
Absolutely.
That we know.
It looks like the Huberman Lab has got some information on that, but it's pretty dense and it's high. He does a lot of high quality work, and he's gonna give you a lot of information. We'll have to, we'll come back to that because but it's interesting. He does talk about that specifically, and so it's funny. Like I remember when I had to get on testosterone. You're on, just for full disclosure, we're both on testosterone replacement therapy with pellet therapy, but I remember when I first got on it. Again, as a consequence of this old dogmatic thinking, I was like, well, I don't want any estrogen in my body, right? I don't want gyno, which nobody wants that for sure. But to the point where I was gonna, smash, as you say, the estrogen, and boy, that was not fun.
Joints ache.
Yeah,
that's
your
another
joints
common
ache.
one.
I'm like, my libido was way off. Like it was bizarre. Like I didn't feel bad. And my energy was fine, but I just was like, my joints were aching. I felt off. My libido was
Mm-hmm.
in this weird off place. I don't know. And, it felt awful, and I didn't realize it.
Mm-hmm.
And then you're right. Then you kind of start tinkering with the anastrozole, and you're like, whoa! And you do this with your patients. It's amazing how little of that stuff you need
You don't need
to
much.
inhibit the aromatase in your body. Right? Would you
Yeah,
agree?
I agree.
So
I was going to say,
early on, did you make some of those same mistakes in your patients, or yourself?
well, yeah, myself, I had to find out my own personal. I
I
think
remember you called me one time. You remember? Do you remember
I'm
this?
super sensitive to estrogen. No, I
Yeah,
don't. What?
you were like, I'm flushing over this. I'm like,
Yeah, yeah.
and I think I was like, hey, did you? Or I can't remember how it came when we talked about your estrogen. Like, oh yeah, but did
Yeah,
you check it? It
I
was pretty
teach this
high.
to patients all day, and I still sometimes forget to take my AI. But I explain this to my patients because this is the most common presentation I see. And tell me if this rings true. I've observed this with my patients. Right? They start out
Yeah.
taking testosterone. They're low. Say they come in at 250, 300, whatever it is. They ramp up pretty quickly. Testosterone's effects are really quick as well. They feel really good, and they're cruising along. Then four to
Get
six
closer to your
weeks
mic.
later,
Get
then
closer to your mic.
4 to 6 weeks later, their estrogen elevates. You
Yeah.
know, the testosterone got up, and now here comes
Yeah.
estrogen, and now they're close together, and they don't feel as good. And the number one thing I hear guys saying is they'll come in for their 6 week labs, and they're like, "I felt great out of the gate, but now I
Yes.
don't feel so good. I need some more testosterone, doc." And I'm like,
Yes.
"Well, let's
Yes.
do some labs first. Let's check because I'm pretty sure I got that
Now that's
dosing
the
close."
mature, well seasoned Jeff. Now hold on a second. Did you fall for, quote unquote fall for that initially? Did you ever say, well, yeah, I guess you kind
Mm,
of do, or did you?
Yeah, I don't know. I fell for it in my female dosing. We can talk about that later. For sure, that was a definite
Yeah.
mistake that I made early on. I was chasing estrogen symptoms in women with more testosterone.
Okay.
In my men, though, I think because I'm not a go big or go home physician, I'm not a more is better physician.
And
What
you're
I
pretty
noticed
data
is
driven.
the as the estrogen got built up in response to this elevated testosterone that they were now having, this exogenous source, it created what I always just describe to them as like a dirty burn. You still felt good,
Dirty
but you
bird.
just also felt a little bloated. You felt a
Yeah.
little moody. You felt a little water
Yeah.
retention. You had a little
Yeah.
acid reflux. You had a little bit of
Yes.
flushing at night. And so, what you really needed was not more testosterone. You needed better, effective estrogen control to drive that down and create a higher difference between those two levels. You didn't need more testosterone.
And
I
there's a biochemical basis for that, right? We talk about women
mm-hmm,
going through menopause and having hot flushes. We know that estrogen has very impressive effects on the vasomotor function of the blood
mm-hmm,
vasculature of your vascular system. So that's their flushing. We also know that it lowers your esophageal sphincter tone. So there's
mm-hmm.
your reflux. I mean,
Yep.
this is classic. You're right on the money. That's exactly what happens. And
But
so,
it's such an odd constellation of symptoms for male patients
yeah,
that they can't really put that together,
yeah,
and so
they're not
they
used
don't
to
understand.
flushing and things.
Yeah, they
Yeah,
just knew they felt better when they started testosterone. Now they don't
yeah,
feel as good. It must mean they need more testosterone. So I've actually
yeah.
over the years I prescribed smaller and smaller doses. I think with better and better results, with better estrogen control. Yeah,
Smaller doses of pellets or smaller doses of
smaller injectables. My
yeah.
dosing on injectables, I think I have done a much better job of dialing in over the years. A smaller, more accurate dose and building is easier than starting high, lowering higher, low. You know, this sort of zigzag approach. Um, Pellets are a different beast altogether than injectables. As a consumer, I completely love pellets. I will never go back to injectables. And I know you, from a data point, really like the pellets as well.
I'm a huge fan of it. There's
Yeah.
more. I listen. I I think if somebody wants right, there's probably an economic reason. Pellets are just they're more costly to produce, and thus they're more costly to the patient.
Mm-hmm.
Um, they're bioidentical, and maybe let's have a separate podcast on that. What do you think? I mean,
Yeah.
it probably deserves its own podcast, so I won't get too much in the weeds. But since we're talking about estrogen control, but yeah, I do too. And then the cypionate is a synthetic, and anyways, I feel like, and this is something interesting. So, would you agree that the cypionate tends to be more quick to aromatize than the bioidentical testosterone that you find in the pellets?
I would say all injectables aromatase at a higher rate, not
Yeah.
necessarily quicker, but at a higher rate than
Yeah.
pellets.
Yeah, that's a better way to
The
say it. Yeah.
things that I tell my patients is both are going to raise your testosterone. I don't
Right.
have any question of that, right? I'm not worried about it like I am with creams. I'm not worried about it like I am with
Yeah.
patches and nasal sprays and yada yadas. They will both raise your testosterone. However, when I look at your hemoglobin and hematocrit and I look at your estrogen conversion, those two are much, much less on pellets as compared to injectables across the
Absolutely.
board. Now, you might be a low converter or a high converter still, but it'll be much less of a problem, which is specifically the reason I choose pellets as a consumer. I don't worry about hemoglobin, hematocrit, never been a problem for me. I'm a high estrogen converter. So much
I am
so
too.
that when I started, that's interesting. Yeah, we have shared genetics there.
Yeah.
When I started injectables, I was down to doing daily shots 5 days a week. I cut my dose, same dose. I took
Oh
the
my
weekly dose and
gosh.
I
It was
cut it,
that
trying to,
bad, huh?
I couldn't, I was trying to mitigate it. And I was like, well, this is silly. I don't want to do daily injections. And then
Yeah.
you introduced me to pellets actually, and you did my first pellet. And so that started that for me. And I was like, oh, just a total game changer. In how my body handles them, and specifically the estrogen control.
So that's interesting. My body, again, shared genetics at least 50%, and from me and you, and then I have the same problem. It was so interesting. I wasn't sure if I had the right testosterone dose recently. My wife is a nurse practitioner and works at our clinic, and she helps me with my pellet therapy, and in terms of getting them inside my body, and I wanted to check my testosterone, see how my levels were, and at the 6 week mark, checked it. This was recently, and I felt off, and I thought I needed more. Turns out I needed less, and I was like
What was your
seventeen
estrogen?
hundred testosterone. I was like, whoa, Nelly. I was like, whoa. I was like, this is way too high. Okay, I need to scale back down. Tell my prescriber to scale me back down. Um, But what was really fascinating was even at 1700, my estrogen was like only 30,
Oh,
35, 37.
nice.
Yeah, and I was like, look at that. Now, had it been cypionate or any of the other injectable forms, just from personal experience and from clinical knowledge and empiric data, it would have been sky high. It would have been
Yeah,
horrible.
for sure. I like pellets for that. I tell patients it depends which camp do you want to fall into. Do you want me and the pellet to monitor you and keep you in these normal ranges? Or are you going to be an active participant in this and be able to report and notice those symptoms and cut your dose in half to maybe a third if you're doing injectables, and be mindful in the onset of estrogen symptoms? And you're going to have to be an active participant in this much more than you would on pellet therapy.
So it's interesting if it's so symptomatic, and it is, and it's a problem, and it's nuanced. At this point in your practice, how do you monitor A and B,
Mm-hmm.
then and treat? Like, do you and then you know,
Yeah.
are
You want
you
some
right out of the
specifics?
gates like the 30% in the study out of Texas that are
Sure.
given aromatase, or
I
how do
don't
you do
mind
it?
giving my protocols. I'll share my trade secrets with you,
Share me your
Jason.
trade secrets.
So, if you're a pellet patient, you start today, day one, right? You get a pellet. I don't treat your estrogen right out of the gate. I want to see how you do or don't aromatize. But I will start you on some DIM supplementation, most
What's
likely.
dim for the people that
DIM
don't?
is a cruciferous vegetable extract that helps
Diindole methane, yeah.
modulate. Yeah, it helps modulate estrogen. It's not as strong. I don't know if obvious or not, but it's not nearly as strong. It does. Here's how I tell other physicians when I'm teaching them pellet therapy: it doesn't treat high estrogen; it
Right.
prevents high estrogen.
Yeah.
So if someone has high estrogen in response to your treatment, too late. You've missed the window for DIM. Let's bring it down with an AI, and then we'll add the DIM.
Yeah.
If you're an injectable person and you start today, I start you out on an anastrozole right out of the gate.
Right.
Um,
Oh, you
Super
do
low
right out of the
dose,
gate,
right out of the gate.
no matter the starting dose.
Correct. No matter the starting dose, I start you at week 2,
Oh,
and I
week two.
start
Okay.
you on a 1/4 milligram a week.
Now, this is a protocol you developed after empirical observation tweak, or did you get this from?
No, yeah, there's a good there, and I don't know of any. Maybe you can tell me if I've looked. There is no evidence-based treatment protocols for estrogen control during testosterone replacement therapy, as far as I know it.
I'm not seeing, and that's unfortunate. I think it's a big problem, honestly.
Yeah. So this is a treatment protocol that I've developed on my own. I started out of the gate week 2, a quarter milligram once a week. And what I find, if I overshoot, meaning too much, which is really rare, about 1% to 2% of males, they go to Q2 weeks at a quarter milligram. And then if their estrogen starts to creep up, I just add a quarter milligram. And my data currently is 85% of my patients are somewhere between once a week and 3 times a week, a quarter milligram.
Oh, okay. Interesting. So you have some people that are up to 3 times a week.
At a quarter milligram. Still less than a full pill, though, which I
Right.
think is the standard. I always tell people the most common thing I see, and I just pulling this from my observation, is if you were a just run-of-the-mill getting testosterone replacement from somewhere, you would do 200 milligrams of testosterone and you do a full milligram of anastrozole a week.
Yeah,
that's
classic.
like boop, just shoot it out of the hip. Everybody gets the same thing.
Yeah.
And some guys do great. That's right. Some guys do fine. That's why they do it, right? You can treat 60% of the patients and not have to think.
Right.
But that other 40% are like, God, estrogen or testosterone just didn't work for me. It wasn't that good. It's because you weren't doing it well. Your doc just took the lazy route.
Right.
And so,
Or weren't
yeah.
properly educated.
Yeah, or
honestly.
weren't properly educated. So I test at 6 weeks. I test at 3 months, and I test at 6 months repeating. That's my protocol. I'm blood
6
work.
weeks, 3 months, 6 months, and 6 months thereafter.
Yep.
Okay. And how quick do you find that you can, at least on injectables, how quick can you find that you can dial somebody in?
Get 3 months easy. 3 months easy. Yeah.
And that's typically take that long, or
No.
at least by 3 months.
At the longest, the longest patient 3 months. We do a little something different in my practice. I promote patient communication. I tell them if you're having a problem, come in before 6 weeks. We have a line that they can communicate with us. That's just for patients on testosterone therapy.
Yeah.
So I tell them at the onset, like I've debated between this. I don't want to put these symptoms in their brains, but if you're having this X, Y, or Z estrogen symptoms,
well, what are those for the people at home? And what are
sure,
those
the most common one I see with guys across the board, gynecomastia is the least common that I see.
Yes.
It's a late onset
late symptom.
Yep.
Yeah.
It's a late onset or patient specific. There's some guys that are uber sensitive to it, but they're few and far between. The most common is water retention, bloating, moodiness, and hot flashes. Those are the big three.
Flushing of the skin is a telltale sign. I see that all the time.
Ears are bright red. I always tell people, if you're going to come in for your 6-week lab, I'm going to see you walking down the hallway, and I'll know if your estrogen's high.
Exactly. It's so
you got a
crazy.
big moon face. You're like, I feel great, doc. And I'm like, no,
and
you
they
don't.
always say they feel great, and they're like, kind of huffing and puffing a little bit. Maybe that's the edema, and then they got these cheeks that are rosy, the ears are bright red, the vasomotor flushing is
sure.
Yes.
Yeah. And so it's, and I see that coming from some people that are doing treatment elsewhere and are switching clinics and things like that. The estrogen, I think, is really nuanced, and it takes it's a big learning curve for physicians to really properly. And frankly, I can't imagine being a primary care, trying to do that nuanced dosing and then walk in the next room and I got a female patient that needs a PAP, and then I got an elderly patient that needs a flu shot, and then I got a pregnant patient the next door. Like, that must be terrible. Like, so I hone in. Super difficult for a primary care. I'm like, I do this all day, every day. Nuanced testosterone replacement therapy adjustments. That's primarily.
It sounds like you would agree with the statement that the prescribing and management of testosterone therapy, or at least to do it in an optimal way, that the patient derives the greatest benefit from, is much more difficult than practitioners realize.
I think it is more difficult than practitioners realize, but I also think it is as difficult as some practitioners realize. Is why they don't do it. But I think they don't articulate it well. I think they have a communication problem, right? What do they say? You don't need that. You don't need that. And what they really mean is, I don't have the time, I don't have the knowledge, I don't have the training to handle this for you. I've got 10 minutes with you every quarter at best to be able to fix this for you. and so they say, you don't need that. Yeah, well, you're good.
Well, that's part of it too. But I wonder if you agree with this. I think part of it too is the mindset of medical treatment that can promote and enhance wellness is maybe discounted a little bit. And let me give you a deeper example of what I mean by that. So we're going to talk about this in a future episode, and maybe we could do this the next episode. Actually, the cardiovascular effects, risks, and safety profile of testosterone therapy. There was a really good article that you and I reviewed together. It was a few weeks ago we talked about it.
Yeah, the New England Journal of Medicine.
New England Journal of Medicine. Yeah, July 2023. This was interesting. Among all the things here, I was looking at this. I had this on my desk, and so let me give you. We can use this as a little teaser, right? Well, this is a little bit of a precursor, a foreshadowing here. They talked about testosterone therapy, and they talked about the fact that the lack of hypogonadism, they described it as a non-life-threatening illness, and the fact, and kind of, we'll talk about it more specifically when we talk about it, if you're willing to do that. But they talked about it as, it's not a, here it is. Quote, however, because testosterone deficiency is not a life-threatening condition, and then it goes on to talk about the uncertainty about cardiovascular outcomes has weighed on treatment decisions by clinicians and patients. And then that's fine to talk about that and why it's tough for people to talk about it. But that's true. That's a good point. But here's the other point of that. That's like saying, in a sense, we're not going to care about you, or we're not going to get too worried about your state of health until it's a life-threatening situation.
Right.
And that right there is what we were talking about, right? I mean, why wait till you get to that point to worry about it? Maybe we should be worrying about it ahead of time so that we don't get to those states. What do you think about that?
Yeah. I I have lots of thoughts about that.
That's a loaded question, isn't it?
Yeah, I'm not happy with the state of traditional medical care currently. I think a lot of that got thrust forward with the past couple of years, and the COVID situation brought a lot to light. And so I disagree with a lot of the paradigms of the current medical model. I participate in the current medical model, and I like to steal some tools and but I want to pick and choose. And I disagree that something that is not life-threatening is not worth treating, because I always tell people, like, what is the gold standard of research? What would you say is the gold standard for a lot of research articles?
You're asking me personally?
Yeah, like what if I'm a drug company and I say, Jason, test this drug and see if it works. What is one of the significant gold standards of whether it can beat what it's effective?
I'm sorry, repeat that last part.
So if I have a drug and I'm saying I want you to test this blood pressure drug, what is a common gold standard that the drug company uses to determine effectiveness?
Like if it placebo, you mean against placebo?
Correct. Yeah. So if this drug is better than what is contained in the power in you to change yourself, if this drug is, then it's like, oh my God, we found the Holy Grail. We just found $1 billion drug because it was better than your brain, right? So there is a lot inside of us that I think can determine our own health. And so to say that once all those systems have shut down and now we're in a life-threatening situation, that's the only time we can intervene, I think is a real misconception of what health should be. Maybe we should start earlier and prevent. Maybe if we treated low testosterone, we wouldn't have muscle loss, and then we wouldn't have hip fractures. Maybe if we treated testosterone early, testosterone deficiency earlier, we wouldn't have a sequel of events that came of that. Now, you have to be mindful and you have to do things safely, but to just say it's not worth treating because it's not a life-threatening issue, I think,
But isn't that interesting though, right? And in
that's
that paradigm. In that context, now I'm purposely using that word. I don't want to. This is a great article by these guys and gals and this whole study group, the Traverse Study Investigators. So I'm not at all demeaning them or being pejorative. because in that context, this is actually a very appropriate statement, and they're kind of being an apologist, and they're kind of describing some of the flaws actually and reasons why people might avoid it. And so I get it, but I thought it was also very telling when put in our context of assessment and what we're looking at specifically. So I don't
Mm-hmm.
want to, I'm in no way detracting from the Traverse clinical trials author, but you're right, and I think what you said was very interesting in terms of placebo and your own ability to for your body to heal itself, or this softer science of whatever positive emotion, the neurochemistry changes, and your ability to. It just sounds silly to say it, heal yourself, but there is a reality to it. And I've seen
Yeah.
that. You and I have both seen it, and I've seen it at the highest level of the sickest patients.
Right.
And as a critical care physician, you
But
just generally
also, let me ask you
well, you
this.
just generally know. I mean, you generally, I can tell you, if I get 10 trauma surgeons in here that are very experienced, it is my belief that if they are honest, or anybody that practices medicine in the acute inpatient hospital setting, you can tell if the patient's kind of given up
Mm,
mentally, they're not going to have a
yeah.
good outcome. Not,
Yeah.
more likely than not, if there's a patient that's determined to get better, they're going to have a
Hmm.
better outcome. And those two, and I'm talking about patient A is, is the same or equivalent to patient B in terms of their age, physiology,
Sure.
a logistic regression analysis, if you will, that they're equivalent. If all things being equal, pathology also being equal, the person that believes they're going to get better, and I've never, I can't put it, I can't tell you the exact molecular, biochemical, neurochemical
Sure.
reasoning.
Because we've never looked down that pathway
Not completely. I think
in a
people are
significant
beginning to,
sense.
but yeah, it's fascinating. I can tell you this patient's just not going to do well because
Let me
I
ask
don't
you
know.
this. I think this is how I practice too is it your right to tell me that I shouldn't do a treatment because you deem my symptoms not worthy of the
Oh
justification for
gosh,
treatment?
absolutely not. I agree. Yeah, exactly.
Who are
And if I
you
have
to
a way to
say
help
what's
you,
important?
what's that?
Who are you to say what's important for
Exactly.
me on either side, right? I think that goes both ways in a sense. I tell my patients this. I'm like, here's how I see it. Here's the pros and cons. I'm not going to tell you what to do. This is a decision you have to make. My role is to educate you, let you see where I'm coming from. Here's my point of view. Here's the data. Here's the results. Here's the outcomes of patients I've seen. What would you like to do in this situation?
Right.
Whether we're talking about testosterone replacement or whether we're talking about cardiovascular preventative measures, those are
Yeah.
both your decision. I don't get to deem the value of any of those. My license says I can't confer known harm to you, and I will hold to that standard. But it doesn't say I have to elevate the treatment of cardiovascular disease over the treatment of well-being. I don't have to elevate the treatment of diabetes over the treatment of something else. Like that's always, I believe in patient autonomy is paramount. um,
Absolutely. Especially when we don't have. Well, we'll talk about this in another foreshadowing, but we didn't have Class A, top tier level evidence, double blind, placebo controlled, randomized data that says, there's an observational piece, or there's some retrospective data, and the dogma says, and my gut instinct says, testosterone is bad for you, and
Correct.
you,
Yeah.
come on, man. I mean,
Right.
if we're going to be evidence based, let's be evidence based. Let's
Right.
talk about practice changing data versus a study where there's a signal in the literature. Yeah, there's a signal. There's a signal. Something's there,
Hmm.
but show me the double blind, placebo controlled, randomized data. Show me the class A or top tier data, and then maybe we can talk, right? And that's an interesting segue and probably into our next foray
Yeah.
into this,
Let's go
because
down that cardiovascular and testosterone replacement talk.
so if you're so you, in fact, I know as your role um, as a medical device rep, and also in advisory role to testosterone practices, TRT clinics and things, how do you summarize in a bulleted fashion, because you got a nice breadth of experience in this, in a
Hmm.
quick little thumbnail, for the audience, the role of estrogen and testosterone therapy and how to control it in men? What would you just real quick give me a little thumbnail sketch to
I
summarize?
tell my practitioners and I tell my patients it will make or break your subjective
100%.
experience with testosterone.
Yes.
It's better to start in small doses and build rather than big doses, whether you're treating men or women. I think it's easier to build in your dosing for women as well as in your prevention for men. And I tell physicians frequent testing is your best friend. Know what you're looking at, right? You have to
Exactly.
that patient needs to understand what it feels like and they'll get good, but until then you got to do testing, you got to check their estrogen levels.
Right. And then lastly, do you ever use anything now DIM for prevention and increasing free testosterone levels and maybe some general health purposes in its other biochemical roles, but have you ever had the need to use anything other than Arimidex to suppress estrogen in your TRT patients?
Yeah, I do. There's some that just don't. There's some people, very few in my patient base, that have a negative reaction. Just don't feel good on it. Just have a negative reaction to
Arimidex?
the actual medication. Yeah, use Aromacin. It would be my next go-to. Or some people
irreversible binding to Arimidex.
Yeah, I don't use it very commonly. It's not
This
my
is
go-to.
interesting.
But my patients who I had a guy this week, and he's just like, I feel like garbage when I take that pill you gave me, right?
Yeah.
And I'm like, what do you mean you feel like garbage? Like, I just get headaches. I just feel,
really?
I can't. Like, he just was having an allergic reaction to it, just a sensitivity to it. So in him, we switched to Aromacin. And in my patients who I just find myself one more quarter milligram, one more quarter milligram, one more quarter milligram, one more. You're like, you're just a really high estrogen converter. Let's go to some Aromacin. We back it all back down, and they tend to do much better.
Out of every 100 patients you would you would treat it through the years and in your case logs and your the whole cadre of your clinical observations, how many times out of 100 are you going to have to use Aromacin? I mean, we're talking 1%. We're talking 1 out of 100.
2%.
Maybe 2. Okay.
Yeah,
interesting.
It's not very common. I like a anastrozole because it's not a permanent, right? It doesn't permanently erase that aromatase, and we don't. But some people need it. Very few people are allergic to it, and very few people need it. But
have you ever used Nolvadex?
I haven't personally. No,
I me either. I was just kind of curious if you ever found the need to do that.
I have some docs, and tell me what you think about this. Have you ever used Clomid for estrogen control?
Never.
I saw that the other day for the first time. I was like, what do you mean he's using Clomid for estrogen control? Didn't make sense to me at all. And he's like, and either the miscommunication from the patient. How often do you use Clomid with your patients, and a percentage would you say?
That's a whole another topic.
I
use it in. Go ahead.
I was gonna say, let me pose it a different way. How many times do you use Clomid in your over 40 population?
Very little.
Okay. That's what I was thinking. I don't know exactly how you practice, but my thought is you probably similar. How about this? Go ahead. You ask the next one.
How many times do you use Clomid in the over 40 population?
Never.
Yeah. Unless there's some decent data that it's been a ways back now, but it was pretty well constructed data, pretty decent data sets, and obviously an institutional reputation that was good, and that was out of the Mayo Clinic, where they were using Clomid to treat androgen deficiency, and just Clomid, and with what was reported as a high degree of patient satisfaction. So if there's anybody that's for whatever reason doesn't want to use testosterone therapy or wants to try an alternative method, I would try that for them. And I've not found it to be, for me, I've not found it to be as satisfactorily successful to my, what I want to do for the patient or what they want for themselves. But every now and then, I would say, 1 out of every 200, maybe, or 1 out of every. I mean, it's rare, but it's nice to have a toolbox.
Let me pose this theory to you. Do you think? Here's my thought on. Tell me what you think of this thought. And I think sometimes primary cares will use it as a way to raise testosterone without giving a male testosterone, so they sort of feel safer and feel better about.
Well, I think that's the thought. I mean,
perception.
Yeah,
it's more natural. That's more natural testosterone, is what I hear.
Right, and I guess to me, because I have a couple of thoughts on that. That's an interesting topic you bring up. My thoughts on that are, at the end of the day, I want to see that number change. It's not, the milligram dose is almost arbitrary in the sense that there's not a goal milligram dose. There's a goal serum level, right? I mean, that's how you're going to induce change. So if the Clomid produces that, that's fine.
Sure.
I get a little worried with Clomid therapy and HCG only because, and this is complete bias, okay? But through deductive reason, I just think there are processes in the body in which we know, tumors form or there's neoplastic changes, or I think when there's constant, either literally constant or pulse in higher volumes, stimulation of receptors that would otherwise not be stimulated in that way. So I get worried about the long term, Leydig cell stimulation, or maybe hypothalamus and pituitary gland. I wonder what that's going to do to people long term. And I don't know. I'm not sitting here telling you I know any kind of, especially randomized control. I don't know any data at all. But I just get worried about that. That's number one. Number two is I tell patients too that ideally, if we knew why you were hypogonadic or had hypogonadism rather, and then you can kind of go down a rabbit hole, right? And you can kind of wear the tinfoil hat. Is it organophosphates or these endocrine disruptors? What's going on in the food supply? What's going on in the whatever however we're getting things in our body that we really shouldn't, microplastics and all these other things. If I could somehow know what that was, for sure, not conspiracy theory, but for sure know, and reverse it for you, and then thus restore you naturally to an optimal, I would do it. But until that time, this is the best we've got, and it's safe. As best I can tell, it's safe. And we'll talk about more of that next time, I guess.
Yeah.
Would you agree with that assessment?
I would. Yeah. And I tell people, so it's interesting you brought up like the cause, and that's a tough one. And everyone has their personal opinion, but I know we've had this conversation. The youngest population base I see with low testosterone, I'm talking guys 200, guys 300, guys in their early 30s with a 250 total testosterone, low free testosterone, there's a few patient bases that are really at a disadvantage. Firefighters, EMTs, police, and lastly, and that's in that order, military.
Military, that's interesting. Well, let's talk about that. Let's have a because you know why that is, right?
They're just, here's what I tell patients: extreme stress, lack of sleep, interrupted sleep, and high stress.
That's exactly right. And this is interesting you bring this up. And so this is completely de novo and, fortuitous or serendipitous.
Sure.
But I recently just for my own personal sake, did a lit search on this because I had always seen that too in shift workers, right? And
shift
disrupted sleep patterns. And there is some pretty good biochemical.
Yeah,
some good published literature.
Oh, is there any data on testosterone though in those populations? Interesting.
Absolutely. So that's so interesting that you notice. Like I noticed that too empirically and observationally on my own, and turns out there's people have noticed it and published on it. So we can talk about that too.
I had a 33-year-old firefighter come in yesterday in the clinic. Had labs from a year ago from his primary total testosterone 300. Primary didn't see any value in putting him on testosterone. I said, let's repeat those labs, see where you're at. He's at 200, 204.
Unbelievable.
33-year-old guy.
Firefighter. And who do you want to have a high testosterone? Maybe the guy that's got to run into
this guy was in the police. Yeah, this guy was in the local police force. But I was like, holy jeez.
Well,
he's like,
have to make a decision to pull a weapon and face the bad guys with the guns and go into a burning house. I mean,
he's like, I feel like garbage every day. It's like, yeah, man, this population's getting abused.
Unreal. All right, my man. Very interesting.
All right, Doc. Another one of the books, brother.
So what do you want to talk about next? You want to talk about the cardiovascular safety profile, and then maybe we'll go into the other things?
Let's do it. Let's do cardiovascular. I've had a couple of recent patients with some concerns, some post-MI patients. I've had a couple, actually some stroke patients, a couple clot patients. So that'd be a good topic. I could talk about how I handle those and my collaboration, if you will, or my discussions with our cardiologists and look at the data and stuff like that.
Perfect. All right, man. Been fun, as always.
All right, brother.
See ya.
Be good. Have a good one.